So I guess I'll start out by talking about the media event we just had across the street, and unfortunately I wasn't able to invite everybody because of the limited space in the clinical microbiology lab. They give a shout out to Anna and Severin. The lab says hello, and they expect you to say hi. Because there's a very close relationship between the Clin Lab at San Francisco General and our public health lab, which is downtown in downtown 101 Grove, in the middle of Civic Center, which I always think is amazing that there's a lab right across the street from City Hall. So we were able to get, for the first time, a really good interest in our media event, and we highlighted the Gene Expert pilot going on in San Francisco General right now. It's been going for about a month, and it nicely coincided, and we're going to talk about this, I'm sure, the FDA relabeling device announcement that came out recently that approves Expert for release, or just says this is an indication for use of Expert, which is to release folks from isolation. And so since January 28, that San Francisco General has been making Expert available through the emergency room and in the hospital ward 24/7 to collect a direct specimen, so there's no processing of the specimen, in order to do an Expert as an evaluation for active TB. And we're going to go through the algorithm that was developed between our TB program and the staff, the lead physicians who were organizing this project. And I'm going to be really interested in hearing what you all have to say. I'm going to have to explain a lot of the intricacies and why we called certain populations low risk, which are traditionally high risk. But again, I think it's going to be a really interesting discussion. So, like I said, we were able to get all the major news outlets, NBC, ABC, KRON, Fox, one of the ethnic newspapers, St. Tao Daily, KQED, they all came out. I've never had major news outlets come out to events. So I think it's because it's something new, and really what happened was I gave a little spiel on what TB is like in San Francisco and why we need this test. And then there was a spiel on what's going on in the hospital. We had then the lab director, Barb Heller, do her this is the lab piece of it, and then we had a patient talk about his experience. And he did a great job and said, I have a message to people. I want you not to be afraid. I want you to go to your doctor if you feel like you're sick. You may not feel sick, but ask your doctor about TB. And so it was really wonderful in that regard. Then there was a demo in the lab, actually, and that's why we didn't have a space for a lot of people. And so it was a nice backdrop with the Expert machine and everything. So I look, and they said it'll start rolling like 3 p.m. today, so hopefully we'll get some air, and I think we heard some radio. So I'm hoping this kicks off World TB, what really should be month, because there's a month for immunizations, there's a month for HIV, there's a month for viral hepatitis. We need to go big. And so we have expanded it by starting this early. So before I start, I do want to talk, and I think this is a perfect day to do this as we talk about Expert, but I want to recognize Anna Babst, who is our senior microbiologist in the public health lab. And you know how I was just here 3 months ago kind of hailing Humpeng. Anna is Humpeng's partner, right? And they worked TB for San Francisco for like 3 decades plus. And so Anna is going to be retiring this year, and I wanted to recognize her. The California TB Controllers Association, really, Expert was piloted with Mark Pandori and Severin in San Francisco, with Anna really doing a lot of the actual ins and outs and the day-to-day troubleshooting and processing of specimens. I think we're really excited, both you and I, that the Clin Lab is now doing some Experts of their own, because it's a good thing. I think it's going to be really, really fruitful. So this is a certificate of recognition presented to Anna Babst, senior microbiologist, for her 34 years of dedicated service and contribution to microbacterial laboratory diagnostic innovation, right, in the public health laboratory of the San Francisco Department of Public Health. So
Doctors Association for this honor. 22 years I've gone there, and I tell you, it's actually have been, as a professional TV laboratorian, this has been the most satisfying time in my professional career. You know, when you start looking about when we first started in the early 80s, I mean, in the late 80s, early 90s, when everything was going, you know, like resurgent from TV, multiple drug resistance, and how we actually work as a group to actually be able to do what we actually have here. So I am so proud that you guys let the laboratory be part of this success. So yeah, it's with really big, you know, great pride and honor to be here receiving this plaque, and I'm glad that I was, you know, hopefully, you know, joining with you guys, be part of, you know, so, you know, being able to have TV, you know, that we have made so much progress with TV. So yeah.
Busy training her successor, and between the lab group, we expect that this is just going to continue, and you guys just do wonderful work for us and for the city as a resource. Okay, so I am going to just try to not talk too long here, and just sort of set the table for our discussion today, because I just can't believe how fast things are happening, in particular with this the use of the expert. Because I think I was taken surprised by the FDA device relabeling. I don't know if you were, but I'd really like to hear more about it from all of you. And so I think the agenda today really is to kind of talk about the experience that San Francisco is having, throw out this algorithm. I think there have been some discussions about trying to create a more regional approach to this, so that there is some consistency in standardization. This is our initial stab at this, and I know that every place is going to be different, but being able to at least air the concerns and issues, I think is going to be really important. So let's see if I can move this forward. Bend it. Okay, it may be slow. Oh. Okay. Okay, so this is just the update on our numbers. We're at 114 cases. It takes, you guys all know, it takes 4 to 5 times that to find your cases and the other contacts. Our quantiferon data estimates 1 in 12 San Franciscans is infected with TB, and that's the number of San Franciscans. So our case rate has just been kind of stuck for now for several years, and you can see from 2010 at least on, we're just sort of sailing along at the same rate and not really making progress with TB elimination. Just the bird's eye view of the way that our program has been using the nucleic acid amplification test, or NATs. Back in 2010, of individual patients having a specimen, 13% got a NAT, and then over time that steadily increased. So 2011-12, 22% of them, and then we kind of plateaued out at 40%. So 40% of our patients have at least one NAT done on a clinical specimen. These are all respiratory specimens. I'm not including the extrapulmonaries, and so that's where we're sitting. And looking at a couple of years of data, the sensitivity of NAT on our culture positive specimens, so this is both smear positive and smear negative, is 88%. False positives were 2%, false negatives less than 1%. So pretty good specificity. And then what I would never have been able to really think about this, the NATs in this way, except for having to put together the progress report for the lab portion recently, was this is what CDC kind of wants us to do, and it's kind of an interesting take on how we use the NAT. but their goal is to have, or the Healthy People 2020 goal, is to have confirmation of TB diagnosis by NAT within 48 hours in greater than 75% of specimens that are ultimately determined to be MAB positive. So I think, that's kind of an interesting way to think about it, and I'm not sure why so anybody who has insight about why this particular indicator. But actually, surprisingly enough, in San Francisco we're doing a pretty good job. I would have thought that this would be more challenging, actually. So anyway, these are our numbers that we were able to nail down a diagnosis in 2010, in 2012, and then this is what the percent and the number that we've been able to make diagnosis within 48 hours have been in the last few years. Okay, now of course, I'm sorry, but I think this might be a big slide. Okay, so this, I didn't print out the FDA, the MMWR article, which unveiled like the FDA's relabeling decision that just recently came out, and I wanted to look at the evidence that they were basing their analysis on, and so there are a limited number of these, but this is a poster that is from the AIDS clinical trial study 34, which Annie Lukemeyer was lead on. And actually some of the patients in the study were recruited here. And this is, the FDA asked Annie to provide data in order to help make a decision about the relabeling. So this is the data, and it's available. It was just presented at the CROI conference in February 2015. And it is available online. It's open source, and Judith can send it out to the group. But there are copies of this. But that's one of the studies. And in this ACTG trial, what Annie showed was that in N of 633 patients were a mix of HIV positive, HIV negative patients. In AFB smear positive, AFB culture positive specimens, one test was concordant in 97%. They missed 2 people with TB diagnoses. When they used 2 tests, it was 100%. The expert picked up 100% of the smear positive, culture positive results. If the smear was negative and the culture was positive, as we predict, the sensitivity goes down. 1 test 55%, 2 tests 69%. If you read the FDA language, they're really not thinking about the AFB smear negative culture positive group. It's eliminated from the discussion in the relabeling. And so I think that was my sort of first take-home point. The other reference that they cite in their announcement is Lippincott et al. That was published last year, and it's an N of 207 patients. And in this study, there were 3 tests that 3 experts were able to detect 100% of the smear positive, culture positive patients with TB, and so that was concordant. But in this study, there were no AFB smear negative, culture positive. So I think what we need to take home, at least this is my initial take, is that when we use expert in this way, we really are not going to have, you're leaving your culture positive smear negative patients are not going to be all detected in this regard. So understanding that going forward when you talk to the hospitals is important. And again, this is me just kind of doing my first pass analysis of this, and so if you've thought about it or you have ideas, this is the time to share. So getting through this is our algorithm, and it may be better to wait until the group discussion to talk about it, but I'll just try to walk through some of the rationale. And again, it took a lot of discussions, repeated discussions, and self-reflection. And both groups, I think the hospital side really wanted to push things because they have an interest in getting their patients out of isolation. And then my side, which is to be more conservative because, you know, ultimately I'm supposed to be the one who's preventing disease transmission. We both gave both ways, which was, I think, in the end, we came to the same place. And so essentially, if you start at the upper left, where you have a clinical history with possible pulmonary TB, if there are symptoms or abnormal chest x-ray, and there is none of that, then there's no testing. But then if there is, you go down your algorithm and you do your first expert. And if it's that first expert is positive, then that's easy. You go down the isolation route and then the traditional GOTCH approval route. But if the expert is negative, then you again have to revisit clinical probability. And I think this is really key because we know the limitations of the sensitivity of expert. So if you have a high clinical suspicion, even though you get a negative expert even the second time, you may actually still go your traditional route of the 3 smears. A lot of the time, though, the clinical probability is low, and the person's coming in for heart failure, but they have scant hemoptysis or something like that. And that's when the rightward arm, the low risk, we then divided up the populations into higher public health risk or lower public health risk. And the thing I'm going to have to explain is I put homeless for San Francisco in the lower risk, and the reason I did that is because we have this shelter screening program. It's very, very robust. We know how to get to our patients. The authority overseeing infection control in shelters is much less stringent than are in other facilities. And honestly, I felt like what we were going to do in this situation was better than what we were already doing with the smears. Because essentially, if there's a low-risk homeless person in the ED, what the ED does before this pilot, what they would do is just refer them to us without any sort of speed up. So the fact that we're actually getting one test is an improvement. And so that's why I rationalized, okay, let's go lower on the homeless population. On the higher group are the ones that you typically have to do the approval for GOTCH, and I felt uncomfortable abandoning the traditional approach. The 2009 NAT guidelines say it's acceptable to have 2 smears and 1 NAT. And so that's what I chose to do as far as clearing those folks. So in other words, I'm not getting 3 AP smears and cultures because the initial expert that you're getting in the ED is a direct specimen that doesn't have a smear and culture associated with it. So you're only going to get 2 smears and cultures when you go this expert rule out route. Okay. So that's how that's for low clinical probability. On the high side, you end up getting a second expert and a second AFB smear and culture. And for the higher side, the public health risk, you still get that 3rd smear and culture. For lower risk, we can make decisions based upon that existing information. That might be somebody who has a house, you know, home, or who's housed, or we have a lower risk. So that, and I mean, I can't reproduce this algorithm out of my head yet because it's just too complicated, and it's challenging to be able to actually implement this with a bunch of providers. I mean, these are residents and fellows, and you know, and so this pilot, which is going for the next 6, it's basically starting in January and it's going to close in June. We're going to see how we do. So, what I can say about the 30 or so patients that we have run specimens on is that we've been able to move in and make a diagnosis within 24 hours from the emergency room in 2 patients. I've been able to discharge to jail, actually, for the low risk, on the low risk side, so this is on the extreme right hand arm. I've been able to send two folks back to jail with one not avoided an admission, another expedited a discharge or transfer back to jail. So I think the early days, and when I reviewed 20 or 30 clinical scenarios, there's only one case where I just thought, I think this guy might still have TB, but it was extrapulmonary, it was pleural TB. So we do actually have, it was our first patient, was a fake out. It was a false negative. So this is the direct specimen, but he fit into the highest clinical suspicion arm because it was a young man who'd spent 7 or 8 years in Korea. And he had, I think, both our chest radiologist and I independently said, wow, that's a beautiful tree and bud on his chest CT. And so we were we did not, the first negative expert really didn't dissuade us. His first sputum that was collected in the ED was smear positive. We took that concentrate and sent it to the public health lab. They did the expert on the concentrate, and it was positive. So I think that just shows you the limitations of a direct specimen. It's not as sensitive. But if you're trying to do things in real time, the micro lab at San Francisco General just can't be relied. They just don't have the support 24/7 to be able to process AFB specimens. And so that's so far experience, and I think that in general, as long as you keep in mind the clinical, just sort of the clinical judgment piece, and that's what it always is, that's really the kicker. So being able to really define your high risk and low risk groups. So these are, this is more of what I was saying before, and I think I'm going to stop here, except to thank Laurel Bristow for doing the numbers for us. She's our new program epidemiologist. And Luke Davis and Amy Lukemeyer, who are the lead physicians on the expert pilot and the expert effort at San Francisco General and UCSF. And then, of course, Anna and Severin for supporting just the use of expert. And the reason why SFGH really wanted this pilot to happen was because it's been such an effective tool for many years prior to this. And the difference now is that the clinicians can get an answer in a couple of hours, where before we were batching our specimens. So it's a matter of a day or a matter of days, and then the SFTV program staff. So I'm going to stop here, and then we should just open the floor for discussion about the expert. And I know that folks are working on a guideline review for CTCA regarding NATs. I just want to be able to start to have a conversation.